life is complex.
So is our mental health. It cannot be understood by diagnosis alone.
Our philosophy is treat the person, not the mental illness.
Hello, everyone, and welcome to another episode of Humanizing Mental Health. I'm Sherman.
I'm Jeremy Alcorn.
And I'm Amy Alcorn.
Well, Jeremy, I'm wondering, for you, when you're treating someone with mental health issues, do you often find, sometimes when you're looking at the individual, because we look at them a lot from the system's perspective, that maybe the family members can almost get overlooked a little?
Yeah, absolutely. As social workers, of course, we look at systems and often we get stuck just in treating that individual.
Mm-hmm. Yeah, and I think sometimes when we're looking at mental health, sometimes, like you said, the individual can almost take primacy. And today we have a guest on the podcast, Dr. Michelle D. Sherman, who is a licensed clinical psychologist, and one of her primary focuses is on doing psychoeducation for persons with family members who have individuals that are dealing with mental health issues. Dr. Sherman has written 2 books on mental health issues, one specifically focusing on teens and another one for the general family. So we'd like to welcome Michelle to the podcast today.
Yeah, welcome.
Welcome.
Thank you so much. Good morning. I'm very happy to be with you. Thank you for the opportunity.
You're very welcome. To start off with, because you've written 2 books, or should I say co-authored them with your mother, I'm curious, what makes you passionate about this specific subject?
Such a great question. So my mom, who is my co-author, she's an advocate and an educator. And I've actually been writing books for families for 20 years. So
Wow.
These are actually our 4th and 5th books. So we've been doing this together for quite some time. And so our passion comes from both my clinical experience as a psychologist. Oftentimes, working in clinics and you see the client, or I worked a lot in the VA, so the veteran, going in for their short, maybe medication appointment and things. And we see all these family members sitting in the waiting room with such commonality of need and experience and challenge. And so I thought back in the mid-1990s, actually, I thought, oh, we have to do something about this. And so I started creating family education curricula. And that's kind of where it all began, actually, in the mid-1990s. And it's continued to this day in terms of my work life and my personal life of working with my mom. The other thing that absolutely informs and motivates and drives our work is we have several family members who also are living with mental illness and experienced trauma. So it's both a personal and a professional passion that brings us to writing these books.
Wow, like from 1990, and I mean, I don't mean to age any of us that are sitting here. That is quite a long time.
Mm-hmm.
So I'm really curious, because when you started that from 1990 to today, sorry, that was me clicking an accidentally YouTube video. We're focusing on our video today. I'm curious about how your process has really evolved over the years.
And I want to clarify, it was the mid-1990s. It was 1990. I am old, but not quite that old. Let's see. Well, some things have changed. Absolutely. I do believe there has been increased awareness and discussion about mental health. Certainly for the pros and cons, there's a lot of social media and education and things like that out there about mental illness and mental health. And although certainly I have concern about some of the information that's out there that's unhelpful and inaccurate, overall there's been more talking about mental health. And I think that's positive. In some domains, such as depression, there's actually been research showing there's some decreased stigma surrounding depression and things. So that's a positive thing. In the mid-1990s, when I started this, there really were not a lot in the VA system of structures and opportunities to engage families. And that has changed a lot. There are many more couples therapies and things like that to engage families. And certainly, NAMI, the National Alliance for Mental Illness here in the States, has been around a long time and continues to be a very important organization to provide free online and in-person support groups for families. So in many ways, things have improved in that respect. However, I'm honestly sad to report that one area of great passion that is part of what I know we're going to talk about today, you know what? In the United States, I don't think it's really changed. And that is identifying and providing supports to the teenagers whose parent has mental illness or trauma. I could talk 4 hours on this, and I won't, but we continue to face many of the similar challenges as we have 20, 30 years ago in the United States. Now, places like Canada, the United Kingdom, Australia, Germany, some of those places are far ahead of the United States. But here in the States, we're sadly really continuing to not identify, even inquire about, and provide supports for these teenagers who we know, as social workers, you know this so well, that they are at higher risk themselves for developing mental health problems. And so my career, my desire, my hope, my prayer is how we can do a better job of early intervention and prevention and supporting some of these at-risk youth.
Yeah.
So some things have changed. Some things, unfortunately, I don't think really have.
Yes, it's really fascinating. As you talk, one of the things that really jumps out at me is I previously worked in the universal healthcare system where individuals would be able to receive mental health care without any payment that they had to make, and there certainly is supports. There's supports for teens, there's supports for children, there's supports for adults, but it's so woefully underfunded as well, and still driven by an illness-based model. That it's like, well, you need to have a diagnosis or a level of illness prior to being served, and that kind of misses the point. Your whole idea is this intergenerational transmission of mental illness that happens within a framework of attachment, really, in terms of how that attachment is interrupted and that person has to build independent or autonomous ways of dealing with things. That means they're not going to build as much community. It means they're not going to have as much internal resources.
Yeah, there are, a lot of factors that can absolutely contribute to the research that shows that they are an increased risk, and certainly attachment. Let's face it, when one is seriously depressed or experiencing a manic episode, whatever else, you tend to be more self-focused, and that's by definition, right? And it's hard perhaps to be available and sit down and play with your 3-year-old or go to your teenager's basketball game. It's hard. And then the partners or other family members, they're kind of by definition, again, fairly focused on the person with the illness. And so the ability of the child to feel seen, understood, supported can be very interrupted in terms of attachment, as well as certainly the genetic component that can be part of the inherited and increased risk. And sadly, what we know is that oftentimes the young people blame themselves. Let's face it, talking about mental illness and mental health and trauma, it's hard for us adults to do, much less to know how to talk to kids. And so sometimes if we don't say anything, then the kids come up with ideas that are even worse than reality. But kids often living with the fear of, is that my future? Am I going to be like that someday? And that's pretty terrifying, especially if no one's talking about the elephant in the living room.
Mm-hmm. Yeah. And, I just kind of want to bring you in here, Amy, because you're now starting off working with youth down at McMahon. And I'm wondering about what impacts you're maybe seeing.
In terms of like mental health.
Yeah. Family mental health on youth.
Yeah.
I think youth, especially like when they're in a system and being like passed around a lot, it definitely disrupts their attachment.
Mm-hmm.
I think it's really important for youth to have like a consistent like parent figure who's there for them. And so when youth are in the system kind of being passed around between many different adults, it definitely disrupts their attachment and can make any sort of like
building of security.
Yeah,
Mm-hmm.
with any sort of mental health issues that they might have, it can make it worse, of course, because how are you supposed to figure out how to heal if you don't have somebody to help you through that when you're that age?
Mm-hmm.
Yeah, absolutely. With that in mind, Michelle, I'm curious, because you've been doing a lot of research on this, and this is a big part of your passion. What are some fundamental ways that you've learned that we can really support youth understanding mental health within their family, or just their overall mental health as their families are going through this?
I think we can think both at the healthcare level and the within family level. I mean, if the healthcare level, if we could even just start getting all mental health providers even asking the question, do you have children? I mean, it sounds silly, but I'd be like doing happy dance. If that can happen, much less how are your children doing when you were in the hospital after you attempted to harm yourself, or you were in a psychotic episode or whatever else. So
Totally.
first of all, if we could even get the question going of, do you have kids and how are they doing? Particularly in terms of crisis such as admission or legal and police involvement, I mean, all sorts of stuff. So to me, that's a kind of basic, and maybe it sounds silly, but you're kind of laughing. So I think you resonate.
Mm-hmm.
We
Yeah.
can ask about and see, because I think they have fallen through the cracks and often invisible. So at a systems level, we've got a long ways to go. I'm actually really looking forward, in about a month, I'm actually flying to London. I'm going to meet with the CEO of Our Time. I'm not sure if you're familiar with it, but it is a UK charity that is actually all about supporting children whose parent has a mental illness. And they do school sessions, they do kind of family workshops and things. And so seeing if we could learn from some of them about some of the supports that they're providing.
I'm not really sure why there is a thumb down.
I see it.
Yeah.
It's not
down on the
me.
screen. I don't even know if it's going to be on the actual
Yeah.
recording or not. Because this is not streaming live, so I don't know what that was about.
I saw that too. I'm not doing anything, so I don't know.
No.
From
Wait, but my hands are nowhere even near my phone.
And if anything, I would be giving you a thumbs up right now.
I say, you don't like what I'm talking about. I shouldn't be talking about this.
No, like when you say that, I almost think like with the idea of like not wanting to talk about this, how difficult is it really for kids to be able to open up and get support from, teachers, friends,
Yeah, totally. It totally makes sense. In fact, as you were saying this, something really jumped out at me. Okay, so how often in an assessment is it that you talk about where did this person come from? So you're asking about what was your relationship like with your mom, with your dad? How did, what was their story, so you can understand how they developed? And why on earth wouldn't someone see it as the other way, to go like, you know what, you're in my room right now. And if your children, or if you have children, they're experiencing a potential small t or big T trauma that is happening within the context of this relationship.
Absolutely. And so why are we not doing that? Now, again, having worked with, as I'm sure you all do as well, amazing healthcare providers, their time is very limited. 10 minutes to do a check side effects, refill prescriptions, blah, blah, blah. I mean, time is limited. And we do know that parenthood can be a reason to get out of bed, a reason for someone to keep living and a source of meaning. And so feeling like I can improve how I am as a parent and my bond with my child can be really meaningful. So that was a little bit of tangent. I'm sorry. But I think the healthcare system is one part. I think what you asked me, though, was more within the family. And so I have a few points about this. The first point is similar to what I said about in the healthcare system, and that is to talk about it. Years ago, we taught parents and healthcare providers not to talk about things like cancer. Don't talk about it. It should be a secret, and we really changed that. And it's the same thing with mental illness. We need to find ways and in words, developmentally appropriate, that children can understand. We're not going to talk about the positive symptoms of psychosis and things. I mean, for a little one, they're not going to understand that. But mommy's really sad today, or daddy's really tired, or my grandma's really angry or whatever else it is, but using words to talk about it is super important. And be open to answer questions, because oftentimes the question may not come when you're sitting down an eyeball to eyeball conversation, but maybe you're washing dishes or you're on a walk or you're driving them to their soccer activity, but finding ways to be available and open for their questions. Secondly, I would say a really important point is to try to remind children they're not to blame.
Mm-hmm.
Often kids think that they did something wrong and it's their fault, that their parent has a mental illness. And so reassuring them it is not their fault. And equally to instill hope, because the recovery is very, very possible. It may not be linear, but there's good reason to be hopeful for your parents, for your family. And so trying to be honest, but also to be hopeful. I think one of the best things and I think the social workers, you'll agree with this, one of the best things for perhaps the co-parent or the family members is to take good care of yourself. I say this to parents all the time. One of the best things you can do as a parent is take good care of yourself. So whether that might mean going to a regular yoga class or your own therapy or your own support group or things like that, but you're going to do a better job of taking care of your kids if you take good care of yourself. Having a support system and things like that is super important. And then we also all know that spending kind of one-on-one time with your child in terms of really that regular ritual that they know that they can count on you to be there for that time. Research shows it doesn't need to be terribly long, actually, but that you have that ritual of regular time together can really build that relationship. And so, there are a lot of things. I think reminding children that actually about 1 in 5 families actually has a loved one living with some sort of mental illness. So they're definitely not alone. They're not to blame. And we want to hear your feelings. We want to hear your questions. And that there is hope, that this is something that your mom, dad, parent, whoever else is working on, and that we're trying together as a family to get help. And in the meanwhile, we're here to support you in the process. Those are some initial ideas.
Yeah, I like on some level, I love the fact that you're talking about using developmentally appropriate language, making sure that, that they still have connection. Because even though on some level, like maybe as our listeners are hearing that it could almost, come across as, oh yeah, why didn't I think about that? But in that moment, it's like we almost look at mental health as this sort of big, overblown thing that, oh no, how do we tackle this?
Yeah,
Just that very basic reminder is so key.
I agree with you, Trent. I agree.
Mm-hmm. One thing, as I was skimming through your book, there was a few things that really stood out to me. One of them that I think a lot of people who have family members with mental health issues really get scared about is the idea of self-harm and suicidal ideation. I'm wondering if maybe you could speak to that a little bit.
Yes, absolutely. It is scary, right? Because that is what I call a relatively low probability but very highly impactful event. Certainly, I think the research shows that many people, mental illness or not, think about, I want to escape, this pain is too much. And so that we live in a time now of a great deal of stressors. And even when we think of one of your first questions is an experience of teenagers, it's a lot different than 20 years ago when we first started writing with the violence, the social media. I mean, the 24/7 news. I mean, there's bullying, online bullying, so many ways in which being a teenager is difficult. And so finding ways to recognize that these young people are probably struggling or their parents are struggling. And so first of all, let's talk about it. It's one of the most important things. And it's super important to help people find ways to talk about it, because there's that old view that is absolutely wrong, that if I talk about it, I'll plant the seed in their mind. That is not true at all true. And sometimes people feel relieved that you could ask me, that we could actually talk about it. So A, talk about it. B, my opinion, and this is, my 30 years of clinical experience, is if you are concerned about your loved one, engage professional help. Because frankly, it's hard for us as professionals sometimes to know their level of dangerousness, whether or not to be in the hospital or things like that. And it's even harder for someone who's not a mental health professional, and it's your loved one. So if you are concerned, we in the States, and I know it's in Canada as well, have 988 that you could call if you're concerned about yourself or if you're concerned about a loved one. So reach out and get support to your own clergy, friend, mental health professional, or someone to get some support, because it is scary. It's certainly at times that people talk about, well, they're just doing this for attention. It's just a cry for help, those sorts of phrases that people talk about. My reaction to that is, even people, if perhaps they are trying to reach out for help or cry for help or things, they may still proceed with harming themselves. So it's still not something to ignore. It's something to take very seriously and engage professional help in quickly. And the final comment I'll make is that, be it a teenager, be it an adult, you may hear, well, they're going to be mad at me if I engage help or get professional help or something. And my response is, yep, they may. But I think it's better for them to be mad at you and them to still be alive than them to have ended their life and you not been able to help them. So that's my basic idea is, yes, certainly it happens. Yes, of course, we have very sad rates of death by suicide. And it's important for families to know about it, to know the resources, know who and when to call, and to take it seriously and reach out for help.
Absolutely. I really appreciate that you said, like, reaching out to the appropriate resources, because sometimes I find that family members, when they think about that, one of their first calls can almost be something like law enforcement or the, and while that may be that gut reaction, it's also about who is going to respond in the most appropriate and compassionate way.
I totally agree, because we know, right, that law enforcement or hospitalization can be very, very distressing for people and can be upsetting. And so whether or not that's what's needed at the time, if someone is in acute medical danger or they're saying, I'm going to do something right now, and they're not willing to get help, maybe that is the time to engage professional, emergency resources. But if they're just sad or things like that, maybe calling their therapist or psychiatrist, their friend. So, but you're right, it's hard to know sometimes, I think, who is the right person to call.
Yeah. In fact, on that lines, if I could chip in some of my experience, recently I saw some research that validated this kind of way of working with things. And that is that I'm always really open with them, that I will talk to you, I will plan with you, I'll ensure your safety. It's only in the event that we can't. But I won't just call the police without you knowing.
Absolutely.
I'm going to talk to you. And I'm going to say, I need to take this to the next level to help keep you safe because I'm afraid that you're going to die. And if at need be, I'll go with you to the emergency room, and I'll help you to navigate that system, so that we can represent you well.
Absolutely. Absolutely. I think that's great. It's a challenging situation for us as clinicians, as well as my members.
Yeah, because once somebody has had the police called on them, then often the next time they just simply won't say anything. And then potentially they die.
Yeah. Yeah, exactly. Yeah.
And I love the fact that you say, I'm going to go with you to the emergency room, because they're not just going to be a patient. They're still going to be a human being.
Mm-hmm. Yeah.
Yeah, and they have someone they trust who's going to empower and support them in that process. So yeah, as you're able to provide support, so we're calling the hospital in advance. Hey, I want you to know that fictional name John Smith is going to be coming to the hospital, and I'm his therapist. He's, letting your client know that you've made that connection can be helpful. So yeah, it's a difficult issue. But a very real one for families.
Yeah. I'm going through all my questions here, and I could probably literally spend about 2 or 3 hours with these. I'm just trying to pick the best ones.
No, I know, absolutely. It's a complex issue.
Yeah, it is. One other thing that I noticed in chapter 10 of your most recent book, you talk about the 4C process for dealing with triggering events. Can you tell us a little bit more about what you mean by the 4C process?
Yeah, so that's in the book for adults. That is not the teenage one, but yeah, that is a way of kind of dealing with triggers. And so when one is triggered by someone's event, or you're having some sort of strong emotional reaction. Let's just make something up. Fictional. This is fictional. Let's say that my husband is living with bipolar disorder, and he discontinues his medication and starts drinking very heavily. Okay. The catch is, okay, hold on. I'm having a strong emotional reaction to this. Let me just recenter with myself. Excuse me. What's going on right now with me? Before I just yell or scream or get out of control of my own frustration. Okay, hold on. I want to pause. I'm noticing I'm having physiological reaction, my breathing, my heart, I'm getting sweaty, my face is red. Hold on. I want to catch myself, because I want to be able to behave in a way that's good for my husband, good for me in our relationship. So number 1 is catch. Number 2 is challenge. And that's not a challenge to the person. That's a challenge to myself. How do I want to show up right now with my husband? Do I want to do maybe some of the old ways in which I can get very critical? I'm shaking my finger at you and blaming and angry and attacking and shaming. Well, no, I really don't want that. I want to be, respectful and empowering, yet honest, that I'm really worried. So challenge. Okay, how do I want to show up right now? And then the third C is kind of change. So based on, okay, I know I don't want to be overly reactive, that I'm very worked up. So catch myself. Challenge. Okay, how do I really want to show up right now as a loving, supportive partner and spouse? And then third is this change. Okay, how am I going to interact differently? How am I going to approach them differently? And then the fourth one I think is very important, and that is to show compassion. So if I do it again in a judgy, angry sort of way, probably won't get a terribly kind response or open response. So if it's more of, wow, this bipolar disorder, these mood swings isn't really hard. And I know that you really don't like the side effects that it causes you to have narrower emotions and to feel really blunted or flat. And I know that you don't like the side effect of X, Y, and Z. And that alcohol really helps you feel more like yourself again. I really appreciate that. It's got to be really, really hard. So empathy, understanding the experience, and then trying to show compassion where, it's sad to me seeing you hurt so much. And I really am on your team and want to help you talk through the options. And I feel scared and worried. I need to make some of those choices. So could we have a conversation about how to handle this really difficult time in your choices? Okay. So that's the 4 C's: is catch, challenge, change, and then show compassion and some kindness. I think that can happen to a lot of different options, not just mental illness, not just interact with a level of mental illness, but the idea of how do I want to be intentional about how I show up in a situation when I'm triggered.
And I love that, like where you say that these skills are not just great for people like when they're dealing with mental illness, but also just overall. And
Yes.
like really when I'm hearing that, like this is a lot of things that will I try to teach somebody as a client, but it's about having it on both sides.
Absolutely. Couldn't agree more. Totally with that. It can help us in all of our relationships and help both the person with the illness and their loved ones. So again, couples therapy can be a great place to learn some of these skills. Family education for loved ones can be a great place. Books, resources, videos, all sorts of things. And podcasts such as this as a way of getting the information out.
Michelle, I got a question for you that I'm curious about. That is, in your clinical part of your practice, do you see then as your primary client individuals that are the ones that are living with the people with mental illness?
Yes. A lot. Because it's kind of like specialty. I mean, I see both, of course. I don't work with children. I see couples and individuals, adults, and certainly many of them live with mental illness themselves, but a lot of them love someone living with mental illness because that's kind of my specialty area.
So one of the system-based things that I'm wondering about, and maybe you can educate me a little bit about this in terms of how this works within the United States. So in our system, someone accessing their private insurance, they don't need a doctor's note. They don't need a diagnosis. They just come in and we just run their insurance. If you're working with someone, do you need some kind of code to be able to charge their insurance? Because is there still like a diagnostic process that needs to happen there?
If they're using their insurance, then generally, yes, one does need to have some sort of diagnosis. And let's face it, what does the research tell us, right? About half or so, perhaps, of people who love someone living with serious mental illness have some sort of depression or anxiety themselves. So
Yeah.
it's not that uncommon that they're having some sort of struggle. I'm not saying that they're acutely in a manic episode or something, but there are pretty considerable rates, and it's understandable, right? If your loved one is really struggling, that you'd be sad or anxious or worried. So it certainly could be some sort of mood or anxiety disorder or an adjustment disorder. I'm having a difficulty dealing with my loved one and his or her their mental illness. And so, yeah, there does need to be some diagnostic code for insurance purposes.
Yeah, it's interesting because it kind of comes back to some of the fundamentals about our podcast that it is really about humanizing the experience, that people, you can't just understand someone from a diagnosis alone. Like our position is treat the person, not the mental illness.
Yeah. And I would almost wonder, because if they have to go in and they have to get a diagnosis themselves, are they also getting stigmatized along with their loved one?
Well, and that's part of that process, right? Of trying to, I guess, push towards destigmatization.
Yeah.
And it's like, I mean, in Canada, by age 40, 50% of people have experienced the mental illness. So, so it's really not that odd. It's not weird. It's actually not. It's just as normal as having a physical condition.
It's almost, and I mean, maybe this is a gross oversimplification, but it's like, eventually, statistically speaking, everybody's going to get a cold.
Yeah, for sure.
I think you're right. I think who wouldn't, right? In some respects, at times feel some sadness or some depression or anxiety if your loved one is really struggling. It's like, to me, I'm not at all trying to or wanting to perpetuate stigma, but rather to normalize. And that's a large part of what our book's about. I mean, the whole first chapter in the book for adults, Loving Someone with Mental Illness or History of Trauma, is all about normalizing anxiety, sadness, grief, anger, loss, all the feelings. And I'm not saying those are pathological, rather those are very understandable. And then we teach kind of research-based skills for coping with them. So I really am not trying to pathologize this, but to normalize.
Yeah, for sure. And I can see how this goes from that micro level into the systems.
Yes.
Like, it's like, okay, we as humans are more like ants and bees than people would like to really think. And we really are a broader organism that function together. Yeah.
Yeah. I love that. And when you're talking about your own individual narrative, like if you were to highlight, because there, in the book, you talk about so many questions in different areas that people can go to, like what is like one of the most fundamental chapters that you would say if people are going to start with something? Would it be start with chapter 1, or would it be like start with chapter 3?
No, that's a great question. For the book for adults, what I'd actually say is to go to the guide, because there's a guide at the very beginning that says, if you are feeling this, go to this chapter. If you want to learn this, go to this chapter. Because every person, every family's experience is so unique that we've done it intentionally, not as something you read like from page 1 to the end, but rather you see what resonates to you. Now, having said that, I do think that the beginning part about normalizing a variety of feelings is kind of universal. I think that's really important. And the other chapters on kind of setting limits and boundaries to enable you to take good care of yourself is also pretty universal. Some of the others may be family specific, such as a lot on parenting. Not everyone has a child, so it might be relevant. A lot on substance use, such a common comorbid condition. A lot on trauma. Now, again, these aren't maybe it's something for every family, but things like communication, limit setting, dealing with strong feelings, these are pretty universal. But yeah, go to the guide at the beginning that has all the points and then which chapters to go to for what you want to learn.
Yeah, and somebody who reads a lot of therapy books myself, because I always appreciate books like that, because sometimes it's almost like you need a bit of a user's manual for what what you're going through. And it's like, I don't really have time to go through this.
Right.
But if I can have a chapter that can give me some skills and some insights within the first 15 or 20 minutes, perfect.
Exactly. And what, as you are alluding to, what we really, my co-author and I, worked very hard in both of these books to make them different from a lot of other books and websites out there that are just information. I mean, we didn't do like, this is depression, because you can Google that, right? Or these are common medications for psychosis. We didn't do that. Rather, it is very much interactive. Here's a story from a family with a lived experience, or here's an activity, or here's a skill, and here's how you may want to try it and apply it. So they're very interactive books, and parts of them are kind of journal-like to encourage engagement with the material. Because let's face it, not everyone's going to go to a mental health professional, or they're not going to go to a support group or things. And so we kind of hope it's kind of like a support group in a book, where you can read other families' experiences, have your experience normalized, and have a chance to reflect on them.
Yeah. So I really love the fact that you say that this is a support group in a book, because I think so many of us, or so many people really do benefit from having a normalized group experience, but a lot of people can be hesitant to reach out, especially in smaller communities where it's like, oh, am I going to be seen or stigmatized for going to this group?
Mm-hmm. Absolutely. I couldn't agree with you more. And there's, financial barriers or geographic barriers, scheduling barriers. Maybe I have children or an elderly parent I'm caring for, and I don't have the ability to go and be with them. And as you said, stigma for certain, access, all sorts of things. And so that's really why we wrote it, is to try to provide that support, validation, and skills to people who may not be able to access or supplement, to those sorts of programs.
Yeah. And I think that that's actually a good place to kind of lead off today. We've talked about a lot today.
Yeah, to start to wind things together, I do have a request though, and that is, if you'll please send forward some links to your book, to websites. If you could email that to us so that we can put that into the show notes. And also, Michelle, it's time for a shameless plug. So tell us, where is it that people can get your book? Give us the titles of the 4 that you've written.
Well, thank you very much. So the 2 new ones are, the one for adults is called Loving Someone with a Mental Illness or History of Trauma: Skills, Hope, and Strength for Your Journey. That one is published by Johns Hopkins University Press and just came out a couple weeks ago. And then the companion one for teenagers is called I'm Not Alone, a Teen's Guide to Living with a Parent Who Has a Mental Illness or has experienced trauma. Both of them are available kind of anywhere you buy books. In Canada, they're available on Indigo, as well as Amazon and things of that nature. And our website, where you can see sample chapters for both books, as well as endorsements and things, is www.seeds, with an S, seedsofhopebooks.com. So www.seedsofhopebooks.com. You can learn more about our background. And there are actually also free resources on there. I know that you'd mentioned, Jeremy, working with the military. There's a kind of cool free a guide that I created a number of years ago. That's a guide for veterans in terms of how to talk to their young people about trauma, about PTSD. It's research-based. We actually did 3-site mixed method research study, and then that informed how we created that. But there's that. There's stuff on talking to kids about deployment. And there are a number of things that are available on that website. So seedsofbooks.com, and you can see information about our books there.
Mm-hmm. Awesome.
Cool.
So we always pull things together with a reflection.
Yeah.
Who wants to go first?
Do you want to go, man?
Sure. I really have appreciated this conversation. The things that have, I think, make this conversation different than some of the other conversations that we have is there's a recognition that often there is someone within a family system that maybe that the primary individual who is carrying significant mental illness, and that is like a cascade that falls across the other members of the family, and for us to remember that. In particular, the thing that jumped out at me as a clinician the most is going, of course, I always talk to other people about their childhood and about what they experienced. I need to make sure that I am doing the opposite and asking you about their children and having that in my mind as a broader window or picture.
I love that. I love that. Thank you. That's awesome.
I'm very much like leading off of like what you said, like looking at this from a broader perspective, and I hope really what's come out of this conversation for people really is more about the normalization, that really kind of coming back to it, that mental health doesn't just impact the individual, but there can be impacts all across the family system, and that you're not alone.
I really enjoyed learning about the 4 C's. That's not something that I had heard about yet, so I think it's really cool to learn how to reflect on yourself and how to work with your family members.
Great.
Yeah, well, thanks again for joining us.
Oh, thank you so much for the opportunity. It was lovely conversation, and I wish you all well in your continued work.
Thank you very much.
Thank you.
On that note, I'm Trent Akers.
I'm Jeremy Alcorn.
I'm Amy Alcorn.
See you next time.
Thank you for joining us today. We hope that this message has been as meaningful to you as it has been to us. If you're looking for help, you can find us on Facebook at Humanizing Mental Health.